Welcome to the Explainer. Right off the bat, I want you to step into the shoes of a clinical judge today. Think about it. On the wards, you are constantly bombarded with a deluge of patient symptoms, alarms, frantic updates, the whole shebang. Your job? You must ruthlessly audit these symptoms to separate the distracting, chaotic noise from the true underlying signal. So today, we're mastering the diagnostic matrix in hematology. We are isolating exactly what matters so you can make the right call when seconds count and lives are literally on the line. Okay, let's just dive right into a high-stakes scenario. Picture this. A patient spikes a sudden fever 30 minutes into a routine blood transfusion. You've got a massive 50-50 dilemma right in front of you. Do you hit the panic button and stop the transfusion immediately? Or do you, just give them some Tylenol, maybe a little Benadryl, and keep observing? Reacting to the noise instead of the signal here can actually be a fatal mistake. To help us build our diagnostic matrix today, we're going to follow a really clear three-part map. First, we'll hit transfusion reactions, then the coagulation interface, and finally, wrap up with an executional pearl on hit diagnostics. Let's kick things off with part 1, transfusion reactions, or what we like to call the temporal pulse. So, going back to that fever scenario we literally just talked about, consider this classic diagnostic comparison. On one side, you have a febrile non-hemolytic transfusion reaction, or FNHTR. It's relatively benign, it's driven by cytokines from donor leukocytes during storage, and it presents with a fever and chills. But crucially, the physical exam is normal, and you get a negative Coombs test. Contrast that with an acute hemolytic transfusion reaction, or AHTR. This is a life-threatening ABO mismatch where host antibodies attack donor cells. The trap here? Both present with a fever. The fever itself is just mere noise. If you focus solely on that, you're going to miss the case entirely. So what's the actual signal for that deadly AHTR? Well, the signal we're desperately looking for is hemoglobinuria. Basically, pink or red urine caused by rapid intravascular hemolysis. Plus, you need a positive direct Coombs test, which proves antibodies are actively bound to the red blood cells. You might also see flank pain or sudden hemodynamic instability. If you see this high alert signal, you definitely do not just give Tylenol. You must demand that the transfusion be halted instantly, and you start aggressive IV fluids right that second. Now let's shift gears to the pulmonary divide. What if your patient doesn't just spike a fever, but suddenly develops severe hypoxia? They're gasping for air shortly after receiving blood. We have another matrix here, setting up two completely different conditions, trolley versus taco. Let's break down exactly how to tell them apart. The clinical evidence here pretty much spells out the mechanism for us. This details TCO, transfusion-associated circulatory overload. When you audit the patient, you'll see clear signs of hypervolemia, elevated jugular venous distension, a widened pulse pressure, and pulmonary edema. TCO is, at its core, a mechanical fluid overload issue. It usually happens in patients who maybe have some underlying cardiac dysfunction and they receive a large volume of blood just way too quickly. Simply put, it's a plumbing problem. To really lock this in, let's compare them side by side. Trolley, or transfusion-related acute lung injury, is a severe inflammatory capillary leak. It's driven by donor anti-leukocyte antibodies that activate neutrophils right in the pulmonary vasculature. TACO, as we just established, is a simple hydrostatic volume overload. So one is this destructive inflammatory storm happening inside the lungs, while the other is just a mechanical overflow of the circulatory system. Which brings us to a classic and honestly super dangerous dumb mistake we see audited on the wards, treating TRALI like it's TACO. First off, you absolutely must recognize that TRALI is an inflammatory leak, not a fluid overload issue. Because of this, step 2 is a massive red flag. Do not give aggressive loop diuretics. If a TRALI patient is already hypotensive from systemic inflammation and capillary leak, blasting them with diuretics is going to catastrophically worsen their shock. Instead, the correct definitive execution here is to stop the transfusion immediately and provide aggressive respiratory support. We're talking non-invasive positive pressure ventilation or even intubation if it comes to it. All right, moving right along to part 2, coagulation geometry and the PTT-BT interface. Here is where we establish the diagnostic dividing line between a pure factor deficiency and a platelet adhesion failure. On one side, we have hemophilia A and B. These represent a pure secondary hemostasis failures, simply because the patient is missing factor 8 or factor 9. On the flip side is von Willebrand disease. Now, this one is a hybrid failure. Von Willebrand factor actually has a dual role. It's required to bring platelets to the exposed subendothelium for primary hemostasis, but it also binds and stabilizes factor VIII in the blood for secondary hemostasis. Now, both hemophilia and von Willebrand disease can actually show a prolonged PTT because, as we saw, they both involve an issue with factor VIII. But direct your attention to the bleeding time. The bleeding time is the ultimate tipping point. Hemophilia has a totally normal bleeding time because the platelets themselves function perfectly fine. Von Willebrand disease, however, has an elevated bleeding time because that absolutely crucial platelet adhesion step is defective. Clinically speaking, we've got to separate the signal from the noise here too. If a patient comes in complaining of easy bruising, honestly, that is just noise. It's incredibly nonspecific and could mean 100 different things. But hemarthrosis, which is spontaneous, deep bleeding into tissues and joints, that is the definitive, high-signal clinical indicator that points straight to hemophilia. Von Willebrand disease, on the other hand, is typically associated with much milder mucosal bleeding. Think heavy menstruation or bleeding that just won't stop after a dental extraction. Let's do another dumb mistake audit, this time for managing a von Willebrand disease patient who needs minor surgery. First, you have to understand that giving them factor VIII concentrate alone is just insufficient. Sure, it helps the secondary hemostasis, but it completely ignores their primary defect, which is platelet adhesion. The precise execution you actually need here is to administer desmopressin, or DDAVP. DDAVP effectively increases von Willebrand factor levels by triggering its release directly from endothelial Weibel-Palade bodies. It beautifully corrects that primary hemostasis gap. And finally, part 3, our executional pearl, focusing on hypercoagulable diagnostics. As a clinical auditor, you need to know exactly which specific lab marker isolates which prothrombotic state. It's kind of like a matching game. Factor V Leiden, for instance, which is the most common inherited thrombophilia, is diagnosed with an activated protein C resistance test. Heparin-induced thrombocytopenia, or HIT, requires looking for the platelet factor IV, or PF4, antibody, or running a serotonin release assay. And antiphospholipid syndrome is marked by the presence of the lupus anticoagulant and anticardiolipin antibodies. Let's zoom in on HIT for a second, because honestly, it's a massive trap. The absolutely crucial point regarding heparin-induced thrombocytopenia, or HIT, is all about execution. If a patient on heparin sees a massive drop in platelets, you must stop all heparin immediately. Do not wait for the PF4 antibody test to come back. Waiting for that test is reacting to noise while completely missing the blaring alarm right in front of you. The definitive execution, switch them to a direct thrombin inhibitor like argatrobin right away. And this is vital. Do not start warfarin until their platelets have fully recovered. Early warfarin can precipitate severe skin necrosis in HIT patients, and nobody wants that. And that brings us to the end of our diagnostic matrix today. I want to leave you with a bit of a provocative question to ponder. In your next clinical challenge, when you're faced with a complex patient and just a barrage of lab values, are you going to react to the distracting noise, or will you strictly audit the presentation to find the true signal? Apply this exact matrix-style thinking, and I promise you, you'll have the tools to master even the most complex systems. Thanks so much for joining me on this explainer. Keep isolating the signal, and I'll catch you next time.